Spinal. So this is part 3 of our 3 videos. So first one went through how to work on a neurosurgical ward, like the day-to-day running of the ward. Second part went through cranial pathology and how to manage commonly called to stuff on the ward to manage cranial patients. So this is going to be really surgical, spinal surgical patients that you're working out, you're being called to manage them on the ward.
Yeah.
Commonly called to pathology and how to manage common concerns that crop up. So firstly, you've got elective and spinal cases, haven't you? So there's lots of elective surgery done for elective and emergency spinal cases.
Yeah.
And there's a lot of elective surgery done.
Myelopathy is particularly relevant because I don't think it's taught that much in medical school, and it's a very common finding, and is good to practice, particularly when you're on neurosurgery. So the patients are often hyperreflexic. They've got present pathological reflexes, so Hoffman's finger jerks and the pectoralis occasionally, or they'll come in with an even clawed hand occasionally, and you can get loss of joint position sense. So they're good patients to examine and get used to seeing, particularly in elderly patients who might be falling more frequently and they've had a sudden deterioration in their mobility. It's something that is quite important that we teach juniors to be able to detect that more frequently, so that when they do go back out into any other areas of medicine, they can also be a bit more confident examining patients and trying to detect it for themselves.
The main things I think will be laminectomies and discectomies.
Yeah, and then the fusions where you're putting in metalwork.
Yeah, and it may be that these are approached posteriorly or anteriorly.
It can be, or even from the side, and you can deflate one lung and go in from the side if it's thoracic as well. So you can have chest drains, and that's not an uncommon thing to have for your thoracic cases.
So in terms of emergency cases, there's spinal injuries that you may get.
Yeah, so spinal cord injuries or major fractures, and then the other side is called equina and or metastatic cord compression or some tumour causing compression. Yeah.
So when you're admitting a spinal patient to the ward, a patient that's had a spinal injury, I guess you manage them similar to a head injury.
Very similar, yeah.
I think the key thing is that these patients need to be worked up as an ATLS patient, don't they? They've often had a high trauma, high energy injury, and they need to be fully reassessed on the ward. They've often been transferred from centre to centre.
Yeah, like you would have a tertiary survey as well.
Yeah.
And often if they're coming to a neurosurgery unit, that tertiary survey should be repeated, or it's sometimes called a quaternary survey.
Yeah. And it's often including the major trauma team at a tertiary trust.
Yes.
If they've had that, because you're going to need lots of specialties involved. But obviously, a checklist of things that you'd want to be thinking about when you're admitting a spinal injury patient. What would you kind of?
So get an ASIA chart out, if particularly, I think it's very useful for just recording everything on, and it's a great snapshot of what a patient is doing at any particular time.
And it saves a lot of time, and it's very clear. You've got a chart there that shows you exactly what to test, and you can write it in the boxes, and even if it's not necessarily to look for cord injury, it's quite a good way of...
and even for juniors that are using it to examine patients post-op for simple lumbar spines, it's a good way of trying to reinforce those myotomes that I think juniors struggle learning to start with.
So get an ASIA chart. Obviously, you want to check whether they need C-spine protection. They should already be in it, and by the time
have a collar of some kind.
Yeah, exactly.
That's well fitted.
Yeah. And I guess all of these patients are at risk of aspiration.
Yes.
And hypotension.
Yes.
They're your two things you want to be monitoring closely for. Considering that on your observations, and if a patient's deteriorating, they are high risk of aspiration.
And we will often keep them on flat bed rest, but that doesn't mean that you can increase, the whole slope of the bed often.
Yeah. So you can actually increase the tilt of the bed.
The tilt, yeah.
And that will often help with reflux. It will help with aspiration, and it will help with just patient comfort. It's not very nice lying totally flat, looking directly at the ceiling, is it?
Yeah, and don't forget standard things like pressure sores. Don't leave them on the trauma trolleys or hardboards for too long.
Yeah.
And they need to have TED stockings and flotrons because they're high risk.
And obviously then they need a really in-detailed neurological assessment. Like we said, best thing to do is use the ASIA chart, but
break it down, myotomes and sensory changes, whether that's light touch or pinprick. Occasionally, if you're interested and there's you can already sense a sensation change, you might also try temperature touch as well, which you can get from often a cold spray of lots of different cold sprays on the ward. So that's quite easy to do. And then the key thing is that PR exam and find out what's happening there, because that changes patients' outlooks from being a bit abysmal and having a very poor outcome to having actually made potentially some recovery. But you obviously don't tell them that at that stage, because it's quite psychologically damaging if you say that you could have an outcome and they don't.
And if they've got a catheter in, you can do something called a catheter tug. I mean, it's not very nice.
Which isn't really a tug, is it? It's more of a gentle just twitch, and to see whether their bladders sensate or insensate. And that gives you a good idea. But it makes up that assessment. Yeah. So
I guess we'll pop up a link to the ASIA chart, but it's easy to find on Google anyway.
Yeah, and then on the back, there's actually some quite useful things. So, for example, if they've got some kind of fracture somewhere, they've got alternative myotomes on the back as well. So if you can't assess one, you can actually use different muscles to assess it via a different way.
It's really important when assessing patients with spinal injuries is to distinguish neurogenic shock, spinal shock, and also that from other causes like hemorrhagic shock. And particularly in the trauma scenario, it's differentiating between spinal shock and a hemorrhagic shock. Clearly, with spinal shock, you initially can get a hypertension and then go into a hypotension and bradycardia, and that's effectively because your spinal cord is physiologically shutting down and has had almost like a sting reaction or stunning reaction to the injury. You get an absent bulbocavernous reflex, you get a flaccid paralysis, and that's particularly there within the first 24 hours. And your peripheral neurons become unresponsive to the brain stimuli because of this initial physiological block. That's different from neurogenic shock, which is where you also get hypertension and bradycardia, but you don't tend to get the changes in the bulbocavernosus reflex. You don't tend to get complete motor flaccid paralysis. And that's more of an anatomical loss of the sympathetic nerve system signals, and typically occurs in the first couple of days after injury. The concern with both of neurogenic shock and spinal shock is you don't want to allow the hypotension to underperfuse the spinal cord, and you want to keep it well perfused in order to enhance the recovery if there is any. Going on from this to autonomic dysreflexia, which occurs typically in the first year after injury, and generally occurs in cord injuries T6 or above, and can happen, more likely to happen in complete, but also can happen in incomplete cord injuries. Generally it's due to an excessive sensory stimulus below the lesion, causing a reflex of vasoconstriction, pale skin, hypertension, and then that subsequently induces a bradycardia and sometimes arrhythmias. Don't forget, above the skin you still get a normal reflex. So because of the the hypertension, you get flush skin, sweating, and all the sympathomimetic effects. The management really is to identify the cause, and 80% of them are bladder issues. But you do want to do a full external examination, make sure that the urinary catheter is draining. You might want to change it, do not flush it, and consider if they've had any constipation or bowel issues. The other things are pain from ulcers, any other parts of their skin, ingrowing toenails, can also be due to anxiety. Basically, got to get control of the hypertension. The easiest way on the ward to do that is GTN spray. is very easy and can be applied sublingually, as well as nifedipine can also be given. And if these don't work, it's critical to involve intensive care support as if none of those are working.
So when you're managing a patient with a spinal injury, it's in terms of, in your plan, you often, one of the key things the nurses will ask you straight away will be, what's the mobilization advice for this patient? So that's quite consultant dependent, isn't it?
Yes.
So that's something you want to be making sure you find out from a senior level.
Well, there's different options. You can either have a soft collar, which is not very sturdy and really doesn't provide much structural support, and then you can have hard collars.
There are problems with hard cervical collars, and there's a whole range of different types of cervical collars as well: Aspen, Malibu, Miami J and Philadelphia. The Aspen is probably the most common one, and don't forget there's a notch at the bottom that you can use to tweak and change the size of the collar. It can give patients pressure sores, difficulty swallowing, talking, and don't forget the increase in ICP, particularly if there is a background of a head injury. There is also halo devices or halo jackets, where effectively you put on a pinned head frame, and then that is attached with 4 rods either side, and it provides better an even higher degree of support. But you can get pins that go inside and crack the skull, so that they are more dangerous and probably a higher risk of pressure sores, even though they've got some sheep wool covering the jacket. And then also there's the braces, so they're really there to prevent kyphosis, and you can get cervicothoracic ones or thoracolumbar ones as well, often just put as CTSO or TLSO braces, and they're quite common in patients who have got stable fracture but that might kyphose.
And then the other option is surgical, where you go in and put metalwork. I think the options are the collar or log roll, and basically it always starts off with absolute full precautions, and then depending on what the consultants decided, then you back off onto something.
Yeah. So a patient with acute cord compression or cord equina, we'd manage them slightly differently, obviously, to a spinal injury patient, because often it's not been a high energy trauma that's brought them in. So it would be the same workup, and probably the best thing to use the Asia chart again.
Yeah, I think the Asia chart is fantastic, and if there's not many on the ward, then certainly get a load printed out, so they're easily accessible. And
I guess the key thing here is the sphincter dysfunction assessment, isn't it, with these patients?
Yeah, so cord equina, you want to do a pre and post void bladder scan, and then also do a PR. And I think it also helps work out what the patient's problems are. And for me, you do a full workup for everyone, so that, if you do find an enlarged prostate, that may give you a clue as to what's actually happening with their waterworks. And it's there to help you. The more information that you can glean from the patient to give you an idea of how to proceed, that's the best way of dealing with it, rather than trying to avoid doing it. Clearly, if the patient doesn't want it done, then again, that just needs documenting. And clearly, for any intimate examination, you need a chaperone.
Yeah, I think often it's not a procedure that anyone wants to have done, but often if you explain to the patient why you're doing it, most will then comply. So
I think most patients don't understand that actually the lowest nerves that will give us a best idea of what's happening to their spine and their nerves in their spine. The lowest one supplies the rectal area and actually inside. And if you explain that to the patient, most of them will. But because of medical legal, always document that.
And then, particularly patients with cauda-equina syndrome, they sometimes need emergency surgery, don't they, to reverse the pathology process or stop progression of it. So I guess the other key thing here is you're working these patients up for immediate surgery, so you don't want to be hanging around with your group and saves. You want to be taking both of them immediately, rather than waiting the 30 minutes. Most trusts will allow you to do it one after another if it's for an emergency, and making sure you've got everything prepared. You've got your patient near my mouth. You've got your preoperative bloods done, booked on the trauma list.
Or at least you've taken one group and saved. Occasionally the anaesthetist will take it in theatre. That's the alternative.
True.
But the key is it often, if they're waiting around for book the MRI scan, because that's the thing that delays them. If you're in a peripheral hospital, and then if it's in the centre, get the bloods done, because that often takes a while for that to get analysed. And so you want to be making those things progressing rather than just waiting on results. And the other side of that is keep the patient nil by mouth, because that's an easy thing to forget.
In the post-operative period after spinal surgery, patients, one of the most common things I get called to is CSF leaks, like we've already spoken about. We've kind of gone through that in Cranial. The key thing here is to have a look at the op note and see if there was any documented tear of the dura, or whether it was an intradural procedure.
Or sometimes there might not even be an intradural tear. You can get CSF leaks without any noticed dural tear. So don't take the op note as gospel, as that it is what was observed, but it doesn't mean that it isn't happening at that stage.
And I guess, like we said before, a stitch early on. Don't just watch and wait.
And always just do a post-op neuro exam. So the most common thing is they've come out of theatre and they've got a high residual. They need a full post-op neuro exam, or PONI for short. So just examine their myotomes, sensory changes, and then it's best to get the bladder scan and work out what's happening. And ideally, again, do perianal sensation and ideally a full PR and DRE.
So you've got CSF leaks that you have to manage on the ward. We've spoken about that. They wouldn't usually routinely have antibiotics again, unless there's evidence of meningitis. Is that right?
That slightly varies.
Does it?
If they've had a CSF leak, some will have some post-operative antibiotics.
Right. And then the only other thing that that you've got to be aware of is if they have an anterior approach in the neck to the cervical spine, then they're at risk of a hematoma, which could cause
block off the airway. And it's been known that either in theatre with the recovery suite and occasionally on the ward, that because of the vast amount of neck movement you get, just sets off some venous oozing, and then that quickly compresses an airway. And the key thing is you just open it up wherever the patient is. So if they're on the ward, it gets opened up, and you're getting someone else to give you a hand. You wouldn't be expected to do that as a surgical SHO or junior.
No.
But you certainly just get help, and if you need, to call for crash call and you just need more help there, that's absolutely fine.
Absolutely, yeah. So I think if you're worried about airway, I've been called a number of times in the night to airway emergencies on this ward. I think, we've got a lot of patients with trachees, they can come dislodged, and obviously there is a chance of post-op hematoma. So each time I've either had critical care or a crash call, because you don't want to imagine that on your own. So definitely a low threshold with airway problems with spinal patients. So when it comes to discharging spinal patients, some patients will actually just get followed up with a physiotherapy team. They won't have to be followed up.
Depending on the unit and how it works, sometimes they will. Again, it varies on the department, but others will want to follow up all their patients in their routine outpatients. Yeah,
and you'll see that in the op notes. The other thing is to consider driving advice, like I spoke about, cranial.
Yeah. And if they've got urinary dysfunction post-op for any reason, they'll often be followed up, even if there is post-op deficits that continue post-op. They often will go to spinal cord injuries rehabilitation centre regionally. If that starts to become normal and it's not quite, it's approaching normal, but it's still slightly abnormal, but the patient can be discharged home, they can still be followed up by them in an outpatient setting by both us and the neuro rehab centre.